Hello everyone, welcome to today's on-series session titled Managing Mental Health Issues in the Workplace, an introductory overview for employers. The topic and expert speaker is brought to you by the Office of Industrial Relations. As a department, we are committed to driving initiatives across the whole scheme that improve safety, well-being and return to work outcomes for both businesses and workers. My name is Alicia Bailey. I'm the Manager of Engagement Services for OIR, and our presenter today is Dr. Peter Cotton. Dr. Cotton is a clinical and organisational psychologist specialising in how work environments influence employee mental health, well-being and behaviours. He works as an advisor to government and the corporate sector. Dr. Cotton has published a number of peer-reviewed research papers and book chapters. The information that will be presented in today's session draws upon Dr. Cotton's most recent research, which was only just released in September. Dr. Cotton was the lead author of the Australian Public Service Commission and Comcare Guidelines titled Working as One, Promoting Mental Health and Wellbeing at Work. Dr. Cotton holds a range of current professional appointments, including Workplace Mental Health Advisor with Superfriend, the non-for-profit Mental Health and Wellbeing Foundation funded by industry superannuation funds, and member Beyond Blue Workplace Mental Health Expert Advisory Group. We are extremely pleased to have the opportunity to share Dr. Cotton's latest work with you, so I will now hand you over to him.
Thank you, Alicia. So today we're going to be talking about a range of sort of issues around this space of managing mental health issues in the workplace. It's a big topic. It's really an introductory overview, but we have weaved in a few practical tips along the way. So hopefully you will have some takeaways that will be meaningful and you can follow up on. So the overview slide there is just indicating the range of issues we'll be covering in this session, and I'm going to go straight into things. So, okay, so first point I wanted to make is that when I'm talking to individuals who are off work with a mental health issue, whether it's compensable, that is they have a compensation claim or not, these are the sort of comments you still often hear. And I won't read them out, but people in this space are extremely sensitive to perceptions of organisational workplace support. So when you talk to managers, it's not really about any sort of deliberate neglect or callous disregard. It's more fear of the unknown, worries about aggravating problems. It's mental health, so we should just avoid contacting them. But by and large, the principle is that we need to try and keep these people connected to the workplace, maintain regular contact, and that's how we achieve much better ultimate outcomes. Now, just talking generally around this sort of space, we still treat physical injuries differently than mental health issues. GPs tend to allow a lot more latitude with certification. Similarly in the workplace, we tend to allow much wider latitude. But the challenge is that individuals in this space ultimately have better outcomes when we have some clarity, some agreed milestones, parameters. Allowing wide latitude often results in more counterproductive outcomes. So for example, I often get referrals for individuals who've been on a return to work program. It's now several months down track, and the question that is asked is, this person is now doing these tasks and not these other tasks. Is there a medical basis for this, or is it about personal preference? So in general, having clarity, having clear milestones, a plan is much better in terms of moving forward. Treatment providers tend to focus on symptoms, but in terms of returning to work, I'm much more interested in what the person can do. So I'm less concerned about how serious the depressed mood is, but more concerned with, how long can they concentrate, what sort of things they're able to do. The other issue that we know in this space comes up is that because it's mental health, often people are diagnosed with total incapacity. However, frequently these individuals have at least partial capacity, and it's much better in the long run if they re-engage with work earlier. I see a lot of people who, given total incapacity certification, go home, they're not talking to anyone, they get more absorbed in their own problems and get worse over time. So engagement with work is generally very positive and helpful for long-term health and wellbeing outcomes. So this is really just indicating some of the background to what we're talking about. And one of the key messages that I want to try and get across is that workplace support has a very significant influence on people's wellbeing and their outcomes, quite distinct and separate from any medical, clinical treatment or even rehabilitation support. And as we'll see in due course, we're not talking about managers becoming clinicians or diagnosticians or counsellors. It's about what you do in your role as a people leader. The return to work literature is starting to recognise this. So there now is an emergent literature that's telling us that people's perception of support in the workplace can significantly improve, hinder or derail their return to work. Perceived organisational support, that's an organisational psychology research tradition, more than 30 years of research in that space, and essentially it tells us that perceptions of organisational support, and what they mean by that practically is that it's the local leader, the local manager, the local supervisor or team leader that is regarded by employees as embodying that perception of organisational support. But that does impact on reporting of stress issues, absenteeism, coping with pain, and the effort that people put into their work, the engagement. We do know that positive and supportive team climates are protective of mental health. If we look at occupations such as police, we know that there are limits to around the extent to which you can mitigate risk. In other words, you can't eliminate risk because that's what the job entails. Going to call-outs, arriving at a domestic situation, etc., and not knowing what's going to happen next. So exposure to risk is part of the job. But what we do know is that if those officers have supportive leaders, a positive, engaging team environment, that's a protective factor and helps mitigate the impact of some of that exposure. The point about grief leadership is it's just an analogy to reinforce this point. In the grief area, this is talking about disasters at a community sort of level, floods and fires and so on. But what's well recognised in that literature is that when local leaders are able to step up and articulate what the community is experiencing, provide a sense of support and direction, that's regarded as having a significant impact on healing with community members above and beyond all the counsellors, all the support from clinicians and doctors and so on. So it's human support distinct from medical support. The health benefits of work agenda, which many of you may well be aware of, is developed by the Australian College of Occupational and Environmental Medicine. It's on their website. The original statement came out in about 2011. There's been a recent update in late 2015. And what this document tells us is that in general, work is good for people's mental health and wellbeing. The mental health of unemployed Australians is up to 4 times worse than people in employment. The evidence update includes OECD research and findings that tell us that work is actually therapeutic, that it helps people get over their problems earlier and reduces the need for treatment. So work is generally good for people's mental health and well-being. So when we're talking about workplace support, as I've indicated, we're talking about being a people leader, not becoming a counsellor or diagnostician. Now, a very important practical tip is this. In my work group or my team, presumably we have team meetings now and then. I don't want all my team meetings to be an endless list of administrative matters or operational matters that we tick off on. What I'm going to do is quarantine a little bit of time in each second or third meeting to have some sort of general reflection on how the team is travelling, open discussion on issues and how the team is travelling. And what I also want to insert into the meetings as a leader is that well-being is on my radar. So, for example, team, we just had a peak period, the pressure's been on, but well-being is important, and anyone who's struggling or have any hassles, please come and talk to me. So that role modelling of the leader validates help-seeking behaviour, and we do know that where leaders role model that sort of behaviour, it does increase the likelihood that staff will go and use the employee assistance program for organisations that have that type of service, or may be more likely to go and see their family doctor earlier. So there is an important role for leaders to role model and validate help-seeking and well-being. And I've seen numerous examples in many organisations where that validation does increase early help-seeking, because the earlier that people seek relevant help and care, the quicker they tend to bounce back. In mental health, we use the analogy of the hot plate. The longer you put your hand on the hot plate, the more damage it's done. The quicker you get your hand off, the quicker you recover and bounce back. So the earlier that people seek help, the correspondingly, the quicker they tend to bounce back. So no doubt you'll be familiar with some of the sort of interpersonal phrases around active listening. So that's genuinely listening to what the person has to say and demonstrating you understand what they're saying. Not jumping in and telling them what they're thinking, but listening to them and then reflecting back that you've understood. As a manager, as a team leader, as a supervisor, building clarity. So regular discussion around priorities, expectations in terms of the work that's to be done, what task priorities there are. Greater clarity is better for individuals in this space. Also, of course, individuals need to feel that you are approachable and accessible as a leader, that if they have issues or concerns, they can come and talk with you. It's not that your door's always closed or that when someone talks to you, you start looking at your watch, but that you are genuinely approachable and accessible. So open communication is critical. And leaders vary in their ability and their capacity to do that. Regular check-ins with the individual who may be on a return to work program or coming back to work. And also getting on the front foot and initiating straightforward care and concern conversations with people who may be at risk. And when we say at risk, we're not talking about diagnosing, we're talking about people behaving differently than they usually do. As a leader, I will try and have my finger on the pulse of the team, and I should notice when people are behaving differently than they usually do. Because I've also validated the message around well-being, it's important, it's part of the way we do business. I'm also going to encourage colleagues, co-workers to also encourage that individual to seek help or make contact with myself. We need to recognise that the default way of coping for many people who are moving into the space of having a mental health challenge or difficulty is that they will try and ignore it and just forge on regardless. So often it is a supportive colleague or manager that is the first to notice that something's not right and the first to engage with that person. There's all sorts of training available in conversations. You know, there's respectful conversations, courageous conversations training, etc., etc., etc. And multiple providers out there. So sometimes an injection of that sort of training does help managers to be more confident in being more on the front foot and engaging with staff. But the key point is about coming across as being genuine in terms of engaging with a staff member. You don't want to convey the message that I'm talking to you because I'm worried about my KPIs. That's going to be completely counterproductive. Straightforward care and concern. This is early intervention. It's not linked with another process or discipline, etc. And often the outcome will be that the person agrees to go and consult your employee assistance program or go and see their family doctor. That prompting through being a supportive leader or a colleague can be very, very important in this space. So when someone's off work, the general principle is about trying to keep them connected to the workplace because that achieves better well-being outcomes in the long run. Sometimes there are some nuances there in terms of negotiating the regime of contact. So asking the person if I can call you on a, next Monday afternoon or fortnightly or whatever. This is where sometimes I'll get pushback from a manager who will say, well, in good faith, I rang my staff member to indicate concern about their well-being. Next day, I got the solicitor's letter saying, stop harassing my client. If that's the situation you're in, that's probably indicating that the person is really wanting to disengage and probably will be unlikely to return, and that's where you need to be talking to your human resources department and looking at where it's going from there. This slide is just talking about people who are anxious in the workplace. Some people are more worriers than others. They anticipate, they think ahead. So particularly in a context of organisational change, they can really arc up. But what this latest research tells us is that perceived support in the workplace, as we've already talked about, significantly offsets those effects. And it's both at a co-worker level and a supervisor, team leader, manager level. So open communication, clarity around expectations really helps these people to cope more effectively. So again, we're not moving into the clinical realm. We're talking about human support as a people leader or as a co-worker. This slide is really just to indicate that what we know is that the longer someone stays off work, the less likely they will be to successfully re-engage in employment. As this graph shows, and this is just based on workers' compensation data, that when you're off work for, say, up to 12 months, the chances of ever then successfully getting back to work are down around 5%. So this is part of the rationale why different workers' compensation authorities and regulators emphasise early return to work. It's not about cutting insurer costs, it's about people's well-being outcomes. The quicker people re-engage with employment, the better the long-term outcome tends to be. I've already talked about the health benefits of work evidence update, so I won't go into this here. You can go and follow that up and find that document on the College of Occupational Physicians website. Sickness certification is a key issue. In Victoria, we've been running what's called an early GP contact program. That's through the Workers' Compensation Authority in Victoria. And what that program has found, that's where the claims are reviewed, and then when people are put off work with total incapacity, one of our doctors or one of our physiotherapists, because physiotherapists can certify in Victoria as well, rings the doctor or physio. What we've found is that the treaters tend to have a mindset of either total incapacity or total capacity, and they don't see the shades in between. So we've found that we're getting a lot of change in certification after those contacts for partial clearance so that the person can start to re-engage with employment. That re-engagement with employment early improves their longer-term prospects. Post-traumatic stress disorder, just briefly, it gets a lot of attention in the media. It's obviously a big issue in our police and emergency services sector, where they have higher levels of exposure to potentially traumatic incidents compared with other industry sectors. It's quite complex because PTSD is sometimes overdiagnosed. If you are an emergency services worker and go to see a GP or psychologist, they're highly likely to then go, bingo, it must be PTSD. But on the other hand, a lot of individuals avoid dealing with their PTSD. Avoidance behaviour is part of one of the elements of PTSD, so it's also underdiagnosed. And in some of the emergency services, there's a lot of self-stigma, meaning you just ignore the symptoms because I should be strong, it shouldn't be a problem, I help other people, so I shouldn't need help. So self-stigma is a big issue across that sector. Further, there's an assumption by a lot of treaters and clinicians that the diagnosis of post-traumatic stress disorder automatically equals total work incapacity. But this is completely false. And I won't read this out, but this is a quote from our official guidelines on the management and treatment of post-traumatic stress disorder, Phoenix. It used to be called the Australian Centre for Post-Traumatic Mental Health, renamed themselves as Phoenix. So keeping the person engaged with work, as far as that is practical, is very, very important. I've been involved in a review of Victoria Police mental health and wellbeing services early this year, and one of our recommendations was around ensuring that we have alternative positions, what we call the interchange bench. State government departments of Treasury are often sort of hovering over and culling, looking for costs for positions to cut, etc. But we need to quarantine some of these positions because we'll get much better outcomes and return to full operational duties when people have these intermediary work roles to engage in. That, as this quote indicates, it helps people maintain a routine, access to collegial support, and so forth. So that really leads on to talking about what does it mean to be psychologically fit for work. And again, it's about functioning more than symptoms as such. So when I'm looking at whether the person is psychologically fit to attend work or re-engage with work, the first sort of area we'll look at is can they attend in a regular and reliable way. By the way, when someone is cleared to return to work with a mental health issue, the medical clearance might be they're fit to start every morning at 10 a.m. Because they're on medication that makes them a bit cognitively slower first thing in the morning, but then they should be accountable for starting at 10. that free-range approach we talked about earlier becomes counterproductive. People fare much better and have much better longer-term health and return to work outcomes where there is some structure, accountabilities, milestones, and that accountability. So are they able to perform the role, actually do the tasks that are part of their role? Further, we all, these days, or most of us, work in team environments. So you have to be able to operate in terms of the parameters of expected behaviours, values, code of conduct. I'll often see people that are cleared to return to work, but they're actually not fit to function in a team environment. So from an occupational health and safety point of view, team well-being is exactly as important as individual well-being. So if someone is creating a risk to the team, then we need to address that issue. Are they actually fit to be in the workplace? Because their behaviour may be having the effect of other people are distancing themselves, feeling alienated. That can lead to a risk to psychological health and safety. So we need to balance team well-being with individual well-being. And of course, we need to make sure the work doesn't make the employee worse. I see many people in areas like child protection workers, police, other roles where people get to a point of genuine sort of burnout, and you might be able to G them up to get back in the saddle, but you know that's going to be associated with high risk of falling over again. So there comes a point when it's better to move on and look for alternative types of work roles. As I've said, functioning is more important than symptoms. So rather than knowing how severe the depressed mood is, I want to know, can the person drive a vehicle and how long for? What are they doing at home every day? Do they watch TV? Are they able to follow a program from beginning to end? Do they use social media or internet or emails? How long do they do that for? That's telling me about their actual psychological capacity. So in that sense, symptoms are less important. It's all about functioning. This is really just providing a bit more detail, which I won't go into, but when we're assessing people in terms of returning to work, looking at a lot of detail around their actual activities of daily living, what they're actually doing day to day, the extent to which they're not doing things they usually do, their capacity, their vitality. As I've already mentioned, in terms of cognitive capacity, I'll ask them about watching television, the extent to which they can read a newspaper, engage with social media, etc. That all tells me something about their actual cognitive capacity. In terms of their interpersonal functioning, are they sitting in a bedroom most days with the blinds drawn, or are they actually engaging with people? To what extent are they able to maintain or continue their levels of social interactions and engagement? Coping, some people resort to things like nicotine, caffeine and alcohol to sort of self-medicate, which can become counterproductive over time. So that needs to be taken into account, as of course the effects of various medications that people are on. With chronic pain, for example, some of the narcotic analgesics significantly reduce people's capacity for driving and decision making, so that needs to be taken into account. So I think we're getting towards the end of the slides, and what I wanted to note here is that we call it psychological injury or stress-related compensation claims, but what we've found is that a significant number of those claims are actually more about low morale rather than about a substantive increase in medical symptoms. But what we do is we tend to medicalise these claims, We give it the, I'm sure some of you heard this, adjustment disorder label. And as a consequence, people become worse over time. In Victoria, we've had a pilot called the Workplace Support Service, which is about triaging claims, and where it's identified that there is a interpersonal barrier more than a medical barrier, those claims are then referred to a skilled rehabilitation provider whose role is to liaise with the employer and the employee and try and resolve those issues. So conflict resolution, vocational guidance, HR interventions are what this group of people really need. Further beyond that, we also get issues around perceptions of unfair treatment, injustice. They can exert a very significant influence over outcomes. I often see situations where the person may actually have a compensation claim accepted, but the organisation has undertaken an investigation into allegations of bullying and not made any adverse finding. So that perception of injustice tends to dominate and also makes people less responsive to standard sort of medical and psychological type treatments. So I guess one of the overall messages from this session is about, from the workplace point of view, that basic human support is very important in this space. It's what you do in your role as a people leader, not becoming a clinician or a counsellor, and it does have a significant impact on overall outcomes and is very, very important. Further, as I indicated earlier, I think probably if I think review everything we've talked about, key practical tip is, as a leader, I want to convey the message to my team that well-being is on the radar, it's important, and people can come and talk to me. So I want to role model that openness and that validation of well-being as being very important. And as we indicated earlier, when we do that, it also makes it easier. From time to time, I will initiate a conversation with a staff member because I might be concerned about them, and there'll be less pushback because we've validated that well-being message. So I think that's, we don't have live questions, so I think we're about at the end of what we're covering today in terms of an introduction. And let me perhaps just summarise again that it's about people's functioning is what's most important, more so than symptoms, and engagement with employment or re-engagement with employment as early as possible is better in the long run. We don't want managers to become quasi-counsellors. It is in your role as a people leader. Now, there's lots of nuances in this space, so perhaps I'll just, the final point I'll make is that when you're supporting someone, if that's taking a lot of time, if they can't return to their usual duties, technically we do have a legal obligation around making what's called reasonable adjustments, but there is a limit to that. The limit to that means that sometimes there may be a situation where someone needs to move into a process of medical ill health retirement because they're not able to fulfil the inherent requirements of their job any longer. That's going into perhaps a bit much detail, but just to indicate that we promote the message of being supportive. Supportive workplaces are better for people's mental health. Supportive workplaces do reduce psychological health and safety risk, and when people experience difficulties, they're more likely to seek help earlier. So that's the key message, validating that earlier help seeking. So I think that's the end of this sort of initial overview. There's a few references there you can follow up. But thank you for attending.
Thank you, Dr. Cotton. We're really pleased that you were able to share your insights for Queensland businesses following the release of that latest research, which is noted on that last dot point on the references slide. So if anyone's interested in accessing Dr. Cotton's latest research, feel free to access it from those details there. We hope this helps empower you in dealing with psychological injuries and as Queensland businesses in taking some of the strategies that Dr. Cotton has actually highlighted today and implementing them in your workplaces. We hope you can participate in future on series sessions, and we look forward to talking to you soon.